There are a few absolute contraindications to neuroaxial blockade. These are patient refusal, localized sepsis, and an allergy to any of the drugs planned for administration. A patient's inability to maintain stillness during the needle puncture, that is also an absolute contraindication, as that may expose the neuronal structure to traumatic injury. Raised intracranial pressure may predispose to brainstem herniation. That should also be considered absolute contraindication to neuroaxial technique. Relative contraindications must be weighted against the potential benefits of neuroaxial blockade. These relative contraindications can be approached by system, neurological, myelopathy or peripheral neuropathy. Though the proof is absent for this, chronic low back pain without neurological deficit is not a contraindication to neuroaxial blockade. The association between neuroaxial technique and exacerbation of the back pain symptoms is not documented. Spinal stenosis. Patient with spinal stenosis may be at increased risk of neurological complications after neuroaxial blockade. Spine surgery. Previous spine surgery does not predispose the patient to an increased risk of neurological complication. Although, depending on the post-surgical anatomy and the presence of scar tissue, adhesion, hardware and/or bone grafts, needle access to the CSF or the epidural space, or the epidural catheter placement may be challenging or impossible in some time. Sometimes there are also unpredictable and incomplete spread of the local anesthetic in the CSF or in the epidural space, also noted. Multiple sclerosis. These patients are more sensitive to neuroaxial local anesthetic, thus exhibit a prolonged duration of motor and the sensory blockade. Spina Bifida. This patient may have a third cord and the ligamentum flavum may be absent. Thus there is increased risk for traumatic needle injury to the spinal cord. Cardiac. Aortic stenosis or fixed cardiac output. It is better to avoid spinal anesthesia in preload dependent patient, as there may be dangerous decrease in the coronary perfusion. However, catheter-based neuroaxial anesthesia may be allowed with repeated administration of the small doses of local anesthetic, as there is more control over the hemodynamic changes in this patient. Hypovolemia. An extension of the patient who are preload dependent, hypovolemic patients may exhibit an exaggerated hypotensive response to the vasodilatory effect of neuroaxial blockade. Hematological thromboprophylaxis. If the patient is on thromboprophylaxis, there is chances for spinal hematoma causing paralysis. American Society of Regional Anesthesia and Pain Management first published a practical advisory to guide the provision of neuroaxial techniques in patients receiving antithrombotic or thrombolytic. Aspirin and non-steroidal anti-inflammatory drugs can be used safely. Clopidogrel should be discontinued 5 to 7 days prior to neuroaxial block. For ticlodipine, it is 10 days. Prasugrel for 7 to 10 days. For intravenous unfractioned heparin, it is better to discontinue 4 to 6 hours prior. For subcutaneous injection, low dose prophylaxis 4 to 6 hours and high dose prophylaxis 12 hours. And for therapeutic unfractioned heparin doses, it is better to discontinue 24 hours prior to the neuroaxial block. For low molecular weight heparin, if the patient is on prophylaxis dose, then it should be discontinued 12 hours before. For therapeutic doses, it is 24 hours of discontinuation prior to the neuroaxial needle placement. Inherited coagulopathy. The safety of neuroaxial technique in patient with common bleeding diathesis is not well documented. Hemorrhagic complications after neuroaxial techniques in patient with known hemophilia, von Willebrand disease, or idiopathic thrombocytopenic purpura appear infrequently when factor levels are more than 0.5 international unit per ml for factor 8, von Willebrand factor when the platelet count is more than 50,000 per ml. A definitive causative relationship between the existing systemic infection and the meningitis or the epidural abscess after a neuroaxial technique has never been shown. However, it is better to avoid neuroaxial technique in febrile patient, as theoretically there is a chance for iatrogenic shedding in the setting of systemic infection.